Hi, this is Dr. Lawrence Wallace with the Larell One Step Denture, and we're going to have a webinar this afternoon, and we're going to go through the procedures whereby we will show you everything necessary for our process and how to incorporate this into your practice and make some money at it too, while providing very good service for your patients. After a brief introduction, we'll go through some of the demographics for dentures. We'll talk about the current market, go through the technique in a series of slides, doing full denture technique, immediate dentures, and implant over dentures. We'll talk about the economics and how to include it into your practices. I know that we have some doctors here who are doing these in nursing homes, and we'll address those issues at some point in the webinar or other situations. I'm Dr. Lawrence Wallace, a graduate of University of Illinois College of Dentistry. I'm a board-certified oral and maxillofacial surgeon, and I'm the developer and founder of the Larell One Step Denture. I enjoyed my practice as an oral surgeon and now felt that it was time to give back to all those people who I removed teeth from over the years. Here are some of the current denture statistics, or edentulous statistics. Currently, 37 to 40 million without teeth. There are approximately 2 to 3 million more per year who become edentulous. Not everybody is able to afford dentures, and not everybody is able to access the care they need for the dentures. Though the article cited at the bottom of the slide states that there'll be a need, will state, and does state that there will be a need for dentures in the year 2020. This article was written in the year 2000, published in 2002. And since then, things have kind of changed. A lot of dentistry has become very expensive. The amount of people who don't have access to dental care has increased. Costs have gone up, making it less affordable. And so there are really more people needing dentures today than ever before. And that number is going to continue to increase. The ADA Health Policy Institute did some research and found that dentist earnings decreased slightly in 2014. 2015 and 2016 were basically flat without increasing. So dental spending is going to remain not so advanced for the next few years. So we're finding in the articles we read and the people we talk to that the average dental practice is down 10 to 15%, and that equates to almost a full day a week. Well, there are ways to fill in that time to serve more patients, to make your life a little better, and to increase your revenue also. And that's what we're talking about in this webinar today. If you think dentures aren't important, take a look at this. If you do a Google search on dentures, and this was done, I don't know, a couple of weeks ago, 15 million entries for dentures. That's quite significant. There's a lot of interest, a lot of traffic, a lot of information about dentures. So today we're going to discuss the Larell One Step Denture, a method for creating dentures in a single visit of about an hour. Sometimes it takes a little longer than an hour. Some cases are a little more difficult. There is a learning curve. But all in all, it's about an hour procedure. It opens new markets. If you are working in nursing homes, it allows you to go to the nursing home and in a very abbreviated fashion, create a finished denture. It's very portable. It's an intuitive, easy to learn technique. So with a basic understanding of occlusion, it really is a technique that can be easily incorporated. Basically, it's used for private practice, although nursing homes and assisted living residencies are tremendous facilities for use of the Larell denture. Many doctors go to senior daycare centers and just put up a sign or a notice in the daycare center that on once a month or whatever, they'll be doing dentures, and they see great attraction from that. Because of the one visit location or one visit usage, it's also used in mobile dental clinics and off-site locations as well. And by off-site locations, I'm talking about philanthropic mission trips, which we do a lot of. I'll allude to them later on in the webinar, but we have done mission trips to Nepal with the NYU Dental School. We've been to Haiti, Jamaica, Peru, Nicaragua, Kenya, and other countries as well. We're getting ready to have a mission trip go to Fiji, where there is a need for dentures, and they don't have the ability to send dentures to a laboratory. They need to be able to do them right on the spot, and that's one of the great advantages of this process. You maintain control over the entire process from start to finish. While the majority are complete dentures, immediate dentures are also significant, and we're going to discuss those at length because too often patients wait until the very last minute to come in to get an immediate denture done because they either can't afford it or are afraid and just don't want to come in. But to be able to offer the patient an immediate denture right there on the spot is a great benefit for many, many practices. Emergency dentures, spare dentures, duplicate dentures, and implant overdentures are also areas that are very highly utilized with the Larell denture. So let's talk a little bit about dentures in general. The three principles for dentures which must be met in order to be successful are fit, form, and function. The dentures have to be able to fit well, they have to be able to look good, and they have to be able to function so the patient can eat comfortably. But there's one more principle that always must be met, and that is meeting patient expectations. This is really significant. In doing the research on dentures over the years, it seems that meeting patient expectations is a significant factor in the success of a denture. Because we don't want to end up with this. We want to end up with dentures that patients come and wear and enjoy and be able to socialize and get better jobs, and not dentures that end up in the jar or the bag and the patient coming in with them. To illustrate patient expectations, this woman came in to get a set of dentures. She was a dentulous. She had been for the last couple of years. She had never worn dentures before. And in discussing with her the expectations that she had, it turned out that she wanted to look like this when she left. And that's unreasonable and wasn't going to happen. So after about a 10-minute discussion of what her expectations ought to be reset and be reasonable, she accepted them and we made the dentures. And because we were able to reset her expectations, we were able to create these dentures in about an hour, and she walked out extremely happy, and they've been successful for her. So expectations is significant. Do dentures in an hour meet standard of care? This is a question that I'm asked all the time. And the standard, you can read the definition of what is the standard of care, and it guides our practices on a daily basis. Many things in our standard of care are not research-backed to great extent, such as the controversy recently that came up about the benefits of flossing. And there are hardly a dentist alive who will say you don't need to floss. And yet those critics said there is no evidence-based research that shows it. So what guides our practice is what's used in everyday dental practice. We accept it as standard of care. It's just used regularly. Now, just to support that, there was a study done in 1996, published in the Journal of Prosthodontics, that demonstrated patient satisfaction with their dentures. You can see the numbers go from the mid to upper 60% to the mid to upper 70% for their dentures. We did a survey of Larell patients with similar characteristics, similar numbers, and we found that our numbers went from the low 80% to the high 90%. So we felt that this supported the Larell denture. The Virginia Healthcare Foundation in 2014 did a research study comparing the Larell One Step Denture to the conventional dentures that they also did. We trained the safety net clinics in Virginia through a contribution by the Virginia Healthcare Foundation to train the dentists to learn to use our process to help more people. The backlog for dentures was tremendous, and they needed a better way to approach it. If you can see, as you can see on the screen, the statistics show that our dentures were equal or superior to the conventional traditional dentures as studied by the Healthcare Foundation being done at the time. We do a lot of philanthropic clinics, Mission of Mercy, EA Cares, Arizona Mom clinics. You can see these were all clinics that were done in one weekend for each clinic, approximately 4 dentists working at a time over 2 days, and we were able to do quite a few dentures. The Arizona Mom clinic from this year and the CDA Cares clinic from just a month ago in San Mateo, we did 120 dentures. And in Arizona, the last one in December of 2016, we did 124 dentures. So we can produce dentures that are satisfactory to the patient, meet their expectations, meet the standard of care, and provide a great service for people who otherwise don't have access to dentures or can't afford them. As you'll see, we use a limited number of models of teeth, shapes of teeth. We have 2 shades available, and I'll go over that more. But using a universal shade and a universal shape, we're able to provide very acceptable dentures to virtually everybody. The main differences between the conventional denture and the Larell denture you can see in this slide. Basically, it's a matter of time and cost. So let's get a little more specific about the Larell dentures. We have 5 sizes of thermoplastic dental acrylic templates. The teeth are already set. What you see in this slide is what comes out of the package. They're available in 2 shades. They're available in A2, which is about 80% of all dentures. But there is a percentage of the population that likes real light dentures, and so they come in a shade B1 as well. They accommodate almost everybody. They don't accommodate everybody because there are some people who have just such odd or irregular jaw structures that a custom denture does need to be made. We studied about 3,000 consecutive edentulous models that came into a large denture lab and did measurements that we provided. We then grouped them with a spreadsheet program, and that's how we came up with the sizes that we did. But there were outliers, and so there were a few that didn't fit. Some can be customized with our dentures, and that brings us up to almost everybody can be taken care of. This just is an example of the difference in the size range between the smallest and the largest. Now keep in mind that the smallest can be made smaller and the largest can be made larger. But believe it or not, this is a size range that will accommodate virtually everybody. We're going to go over a few cases right now. Everything that you're seeing will be repeated at least once, and then it will be seen in the video showing the entire case, narrated by me, of course, through video. So every point that is seen in these slides and the different cases that we're going to show will be repeated. This is a patient who required a full denture. The first step, you can see the dot on her chin and on her nose. Standard method for determining vertical dimension. That's always the first question I'm asked. How do you get vertical dimension? You have the patient stand, you have them swallow a couple of times, put the dot on their nose and their chin, have them stand there relaxed, and make the measurement. If you have no teeth, if you're a dentulous, vertical dimension is a guess. It's a good guess, but it's a guess. Only if you have teeth in place can you determine directly and exactly the vertical dimension. So you make the measurement and set that aside. The next step is an alginate impression of the upper is what we start with. We start with the upper. We pour up a quickset stone model and fit the template that fits the closest to that. And we're going to go through those steps. The upper is done first. If you're doing it in a nursing home or you have a different situation you're working with, you can use a compound called nogenate, which is a syringeable alginate substitute. Also, if you find it difficult to carry stone and can't use stone in whatever situation you're in, you can use a heavy putty. Heavy putty mixed can be put into the alginate impression, let harden for a few minutes, and use that as your stone model for the denture. The idea, of course, is to fit the template directly to the model. And as we know, jaws are very different sizes, and we're going to show right now how to determine how to do that. So the first step is to take the model, take the closest fitting by looking at it with your eyes and seeing which one appears to fit the closest. Turn it upside down on the model, see if the teeth are over the ridge. Try it in the mouth and see if there's areas, and there usually are, where the frenum or flanges need to be reduced. And you can see a little bit has been reduced in that lower left photo. The idea, and you'll see that again, is to create a template that is leaving you 2 to 3 millimeters of flange space for the reline material and have all of the muscle attachments cut out. When this template is at room temperature, it reacts as if it's standard denture acrylic. An acrylic burr in a Dremel or an electric lab handpiece is ideal for trimming the flanges of the template. We do want to get it fitting close. We do want to have 2 to 3 millimeters of space. We do want to have it fitting the palate well, and we'll show you how we go about doing that. So after we've tried in the template on the model, we know we have to fit it directly to the model. So we then take it and put it in boiling water for about 45 seconds. The templates are thermoplastic acrylic, so after about 45 seconds, they will become malleable. You'll see that in the video, how malleable they become. Once they are, you can press them right out of the boiling water onto the model. You will want to wear rubber gloves, but they're not really hot after the first 2 or 3 seconds. Our earlier cases, we actually put them in the boiling water and then after 5 seconds brought them right to the mouth to try and adapt. This can be done, but it takes a little longer. So the first step is to place it on the model, impress the palate so you've got as little space between the template and the palate as possible, and then trim the flanges so you have it looking like it does in this photo, so that when you do the reline, you will avoid muscle attachments and leave enough room for the reline material. The reline material, and we're going to go through all of this again. The reline material is mixed up into the proportions that the manufacturer suggests. It is placed into the template, which has now been fit to the mouth. Now basically what you have done in fitting that template in that first step is to have the custom tray, the wax rim, and the wax try-in all at the same time. These teeth are individually set, so you can customize them before you do the reline. And we'll go into that in greater detail in the next cases. We try the template in with a Fox plate. We want the elytragal line, occlusal plane to be proper. We want the horizontal line to be proper, the Frankfurt horizontal, the pupillary line. And we do that so the upper will fit with the right occlusal plane, and the lower will just drop right in and match it. The upper is done first. When the template is tried in, the patient can speak. They're asked to say a few words so that we can see that the incisal edge of the upper incisors is touching the wet dry line of the lower lip. to see that the speech pattern is right. If it needs to be adjusted, it can be adjusted by putting that segment in the boiling water, letting it become malleable, and adjusting those teeth. As I said, they are individually set, so they can be rotated for natural characterization, or they can be moved up or down. There are two other planes that need to be looked at: the anterior-posterior position and the vertical position of the anterior teeth. And those are done visually by trying in the template. And you can see in about a half a second if that looks proper. If you need to reset the template, not reset it, but be able to duplicate the template, you can do that easily by putting in stops, and we're going to show that in the customization section. So now we have taken our initial impression, we've poured it up, we've fit the model, we've now taken it to the mouth and done. The initial reline is done with the material that we're going to tell you about in a little bit. It's Flexacryl by Lang Dental. It's a chairside reline material, and it is able to be easily manipulated. That's the material that we've chosen to use for our chairside relines. The upper left photo shows the template relined and just taken out of the mouth. The upper right is a side view of that photo. The lower left photo shows the initial rough trim, meaning it's just the excess that's taken off. The lower right photo shows the completed template, but there's a couple of steps in here. We're going to go over those. Once the reline is done, and as I said, we're going to go over all the steps in this procedure multiple times. Once the reline is done and it's been repeated with the lower, articulating paper to balance the occlusion and pressure indicating paste to remove any high spots is important for comfort for the patient. By doing this and by making sure that we have done this properly, and I'll get into that in a bit, meaning the pressure indicating paste at least 3 times to remove those spots, as you can see in the ruga area, or on the right side of the photograph, there's a high spot there where the pip paste has come through. Adjusting those at least 3 times makes for a total later denture adjustment level of about 10%, which is pretty low. So there's the finished case. Now, we did skip a couple of steps. We did skip the lower, and we're going to go through all of these in other cases that we're doing. This is a different case, but to show the occlusion, we use monoplane teeth. We studied the dental research, and it showed that monoplane teeth are about 85% as efficient as cusp teeth, but they're much kinder to the tissue. They cause less resorption, and they cause less problems for the patient in function, and yet they're sufficient for function. This is in a right protrusive movement. The monoplane teeth create it very easy to balance that occlusion. Left working occlusion and protrusive. By having this situation, the patients are able to function real well. There's a couple other things in the templates that we've done, and as we go through the webinar, we'll talk about those. Now, as we all know from practicing dentistry, nothing goes perfectly all the time, and we have to be very nimble to correct issues that come up. As I said earlier, the templates are customizable. In the case in the left-hand photo, the template was the right size, but the teeth were not over the ridge. So we took a burr, created a notch down the center while it was in the room temperature state. And as I said, when it's in the room temperature state, it acts and looks and feels just like standard denture acrylic. Once it's heated and becomes malleable, you can't take a burr to it in that state. So we were able to create this notch, bring the posterior teeth together, and I'll show another case of this, and then be able to take it to the mouth for the reline. That's one of the things that you do to customize it for the patient. We didn't have to touch the teeth, only the flanges in this case. The photo on the right side shows 3 impression material stops in place. Once you've tried the template in the mouth and you've got it to where you want it, if you would like to replicate that position for the final reline, you can place tripodal stops with the reline material. It takes about 3 minutes to set up. You can be certain that you have it in the spot that you want it, then mix up the final reline material, place it into the template, and place it into the mouth until it goes to the stops. Now, if you noticed, I haven't talked about the lowers very much. I'm going to show this customization of the lowers, and then we'll talk about the lowers. As patients lose their teeth and are edentulous, they tend to resorb anteriorly in the mandible and posteriorly in the maxilla. So that a patient who's been edentulous for some time typically will have a class 3 appearance. Some begin with a class 3 appearance, but most don't. Also, after being edentulous, the condyles tend to slide down the eminence, and so that further increases the class 3 position. This is an example of customization for an extreme class 3. And what we had to do was create this notch all the way from socket to socket, and actually took out the premolar tooth, put it in the boiling water, and bent this segment all the way back before we did our reline. And we had to create a smaller lower denture so that we had less of a class 3 appearance. Now this can be done, also you can use a smaller size lower. Sometimes that's all you need to do for that. This is other customization that can be done. You can see in the upper left photo that the teeth in the posterior with the template tried in. This is an immediate denture case, and I'm going to go through this entire case in just a couple of minutes. But you can see what we started with. He kept his natural lower dentition. This was an upper denture against natural lower dentition. You can see that when we tried the template in after the surgery was completed, the posterior maxillary teeth were way off the ridge, and there was an open bite anteriorly. And we were able to create the denture you see in the upper right photo. So we'll show you every step of the way on this case in just a minute. If the gingiva is too light, there is a tinting concentrate that comes with the kit that allows you to add a pigment to the monomer of the reline material. Nothing is done to the template itself. It's done to the reline material, which then darkens the reline material. It shows through the pink translucent template for a darker pigmented color for African American patients and others with very dark skin that don't look real natural with a light pink color. This was done with an extreme amount, just as an example, versus the standard right next to it. Right at this point, I want to talk a little bit about the lowers. Everything we've talked about is the upper. We answered the question, how do you develop vertical? And the other question I get all the time is, how do you get the occlusion? Well, all of the occlusion is based on the upper template. If you get the allotragal line properly set with the occlusal plane set, and you have the aesthetic set visually, and the anterior posterior lip support set visually, and reline that denture, you now try in the lower denture, and you can match the occlusion to the lowers. Again, just put it in the boiling water. Let it get malleable and manipulate it. If the manipulation is 1 to 1.5 millimeters, you can just put it in the boiling water for about a minute, because the thermoplastic is thicker in the area of the teeth than it is on the flanges, and then manipulate the teeth. If it's more than about 1.5 millimeters, you do need to create a notch. One of the other items that I'd like you to take a look at is in that lower photo on the left-hand denture and the right-hand denture, is there is only 1 premolar and 2 molars. That is done specifically. The research has shown that the buccinator muscle comes right across the second molar, and in natural teeth it's not an issue, but in dentures it is an issue and can be an issue, and the buccinator tends to unseat that lower denture. So what we have done is we've made the occlusal table smaller by removing one premolar. So there are 2 molars and 1 premolar. Now the buccinator runs over the retromolar pad area where the second molar might have been and helps actually to keep the denture seated. Research has shown the 3 posterior teeth as well are sufficient for occlusion. Over the years, I've had a couple of reports of dentists who say the patient wants the 4 teeth that they had in their other denture. And what's happened in both circumstances, which I recommend doing, is saying to the patient, you work with these teeth, you work with these dentures for about a week or 2 weeks. If you find you feel you're missing anything, then you come back and we will put an extra tooth in. Of the instances where that's occurred, nobody has come back to get it done, because once they get used to it and see that they can function well, they don't have an issue. We're asked often about cosmetic dentures. To me, there's no such thing as a cosmetic denture. There's cosmetic results. That goes back to the principles of fit, form, and function. It's got to look good. And by opening up the vertical to the proper dimension for function and setting the templates in the proper position, you can create the best kind of cosmetic denture. We're now going to do 2 cases of immediate dentures. These are done regularly. They're done all the time. They're very, very successful. I say that the standard denture, the Larell denture for the edentulous mouth is comparable to a traditional denture, but I think the immediate is superior. And the reason is going to be evident in a minute. This patient came in, she had 4 teeth in the maxilla, needed to be removed. She was in pain. She didn't want to have an immediate made and wait 2 weeks while that happened. She couldn't afford to have 2 dentures done, and so the lower anterior teeth were going to be left. So contraindicated to standard technique for an immediate, the first step we do is take the teeth out. We then take an impression of the jaw, in this case the maxilla, and pour up the study model to the post-surgical condition. What that will do is allow us to fit our template and have the best fit of the upper immediate. In my practice as an oral surgeon, I must have delivered hundreds and hundreds and hundreds of immediates. And when I make this comment at lectures, I get nods of agreement all the time. They seldom fit. Only about 30% of them fit. But by fitting the template to the jaw after the surgery, you get a much better fit for that. So the treatment plan for this patient was make the immediate upper, leave the lowers for now. She would come back at a later date, and we would make the lower denture. Now, because this woman had teeth in the maxilla and mandible, she was able to have a hard stop for developing vertical dimension. And as I said, if they don't have teeth, it's an educated guess what vertical is, but it's a good guess, and we're usually pretty good at figuring that out. So after the surgery was done, the model was taken. The template was tried in. It was tried in the mouth. The frenums were removed, muscle attachments were removed, and you can see the example of that with the model for the lower in the lower photo. The template was then tried in the mouth. Now we're going to get a little bit into the technique for the reline, and again, we're going to go through these multiple times, and you'll see it in the video. A sealer is placed into the template, which has now been fit and tried in, and we know is correct. So it's a sealer primer that's placed into the template prior to the reline. The reline material is mixed up to a creamy consistency. We want it just stiff enough so that it does not run when you place it in the mouth. And you basically fill up the template. The ideal situation, of course, is that you have adapted the template so closely to the model that you'll have a very thin layer of reline material. The upper right photo shows the completed denture with the post-dam in place, and we're going to talk about the post-dam as well. The 2 lower photos are this patient that we just showed you with her finished denture in place, and she was extremely happy with them. She wore the dentures, came back at a later time, and was able to have the lower denture done. The post-dam that you can see in the upper right photo is placed after the rough trim for the maxilla. It's not done in the mouth, it's just mixed up, and a bead of about 1 millimeter by 1 millimeter is placed right across the posterior, and it's allowed to set completely firm. So that's 3 to 4 minutes before being placed in the mouth. If you place it in the mouth prior to that, it is not firm enough and it will displace and loses the ability to create the post-dam seal. We're now going to show an immediate denture with modifications. This was the case I alluded to earlier. Patient was to have all of the maxillary teeth removed, those 2 root tips in the mandible. The lower right second premolar was being restored and kept. The remainder of the lower teeth were being kept. So the idea was to make him an upper immediate Larell denture against lower natural dentition. The surgery was completed, the alveoplasty was done, and it was completed and sutured. The impression was then taken and the model was then done. So we know we're going to have a template that is adapted to a very close fit to the post-surgical model. The template is then tried in the mouth after it's fit to the model. And here's the template on the model. And this is the photograph you saw earlier where you can see that the teeth in the posterior are off the ridge and that we do have an open bite. So we're going to do some immediate orthognathic surgery. Patrick, if you're still listening, this is where we do instant orthognathic surgery. We take the template, put it on the model, create a notch in the center, and brought the 2 posterior edges in. That brought the teeth over the ridge, and you can see how much closer at the posterior, far posterior line the denture template is than it was in the wider part of the notch. We then take a diamond disc and create a disc, a notch distal to the canines. The purpose of that is because we're going to be closing this open bite. And you can see in the upper right and upper left photos the notches that were created with the diamond disc. And also in the lower left photo from a occlusal standpoint, you can see the notches. The lower right photo shows that those notches were carried through to the intaglio surface of the denture, and that was done specifically, and we'll explain why in a minute. So the notches were made. In the upper left photo, you can see the 2 notches, and then we take the template, place it in the boiling water, get that segment malleable, and bend that segment down, and you can see in the upper right photo that these notches have been closed and there's no open space. We're now trying it in the mouth. You can see preliminarily that the open bite is almost closed and that the posterior teeth are now over the ridge. You can take it to the hot water, the boiling water, multiple times. There's no memory to the acrylic, so you can do it as many times as you need. The reline material is then placed into the template. And the upper left photo shows some of the reline material coming through the notch. That notch that we did, some of that, a little bit of that material came through, and we used that in order to recreate the papilla for aesthetics. So the lower left shows that template after it's been relined and taken out of the mouth, but not touched yet. The lower right shows after it's been trimmed and the post-dam is in place. One of the doctors at one of our seminars said, how do you know how big to make the post-dam? And my response to him was, well, when you send a case to a laboratory to have a denture made, do you tell the laboratory how big to make the post-dam? And the answer is usually no. So it's the same thing here. We're just going to estimate what the post-dam will be, but it doesn't really need to be more than about a millimeter in both dimensions. You'll see that in the video. So here is the template relined, tried in the mouth. You can see that it still has some adjustment to go. It's adjusted with articulating paper, pressure indicating paste, and the lower left photo shows the finished denture. Now this fella came in and he was in pain and he wanted this done. And as I said before, if you have to make the immediate and have the patient wait a week or so, they're usually not happy. But this way you can complete the case on the first visit and get some really good word of mouth for your practice because of that. For completeness sake, I'm going to discuss a two-step process which is often done for nursing homes. Since the patients are always around and access to the patient is always available, and many doctors do go back to the nursing home several times, so they know that if they needed to do a second visit, it doesn't create a lot of problems for it. This case will demonstrate that. The immediate step is to take the model and fit the template the same way. Teeth over the ridge. You can see there's 3 posterior teeth on each side. Templates are adapted, cut out for frenums, adapted closely in the palate, same way. However, from this point, instead of relining them with the reline material, we use a PVS material and put that into the upper template, which is your custom tray, wax dry-in and wax rim all together, because you can and should customize the teeth as you need it for the final look. So you place the PVS material into the template and then place them into the mouth. Have the patient bite down in occlusion and then use some bite registration paste to develop the right centric occlusion. So this can all be done on that first visit. Once that's done, it's taken out of the mouth. So basically we have a finished impression, and what will happen is this will go to the laboratory and it will have a rebase done. And those teeth will be in that position, in the final position for the denture, and it will be completed on the second visit. So the denture is rebased, finished, polished, brought back to the patient, and done at the second visit. This is an alternative to doing it in one visit. Some doctors like to do it that way in their office. Most like, because of the single-step process, to do it that way. We're now going to discuss some dental implant procedures, how our dentures are used with implants. This patient came in to have the maxillary teeth removed. We've gone over the basic process, so we'll just show different bits of it here. So the process was, the treatment plan was to take out the teeth and create a Larell denture for her on that day, which was done. The dental implants were placed also on that day. The patient then wore the upper template for 4 to 5 months while the endosseous implants integrated to the bone. The patient came into the dental office, the implants were uncovered, and the abutment posts were placed. I think these are analogs. Another Larell template now, because this is 4 months later, and you can use the same one ground out, or a new one, is used right over the implant abutments. And you can see that that's what the preliminary impression with the template, right over, that's on the template, right over the implant abutments. The area where the implant abutments are is relieved. The final housings are placed onto the implants, and then it's tried in the mouth, and then the housings are picked up into the upper denture. This is a pretty standard technique, but it works really well. Now, can it be done all at one time with immediate load implants and picking up the housings right on the initial reline? Yes, it can. It depends how it works in your hands. So the housings are picked up. The palate, in this case, because we had 4 implants holding in the denture, didn't need the palate for support. The palate was removed. The final attachments were placed into the housings, and it was placed into the mouth. So here we had a wonderful implant-retained upper denture with no palate. Patient was thrilled with this. All done in one visit after the implants were healed. It had to go through the other process. But as I said, if you want to use immediate load implants. And if you're doing denture against denture, that is an indicator for immediate load implants. This would not be a case for that because the patient has natural lower dentition, and the natural lower dentition really doesn't do real well with immediate load implants. It creates too much chewing force. So here's a mandible case. This patient was to have all of her teeth removed because of decay and periodontal condition. She was going to initially have no implants done, but when told what the cost would be for a set of Larell dentures, which was significantly less than the standard denture, she said, wow, I can afford to have some implants placed. So she made the decision to have 3 implants placed to help stabilize the lower denture. Now, as we all know, if you can stabilize the lower denture with implants against an upper denture, you're going to have a superior resolution. Implants with a lower denture is becoming the standard of care, and it is used all the time. Gordon Christensen has stated recently that implants with dentures are becoming the standard of care for denture patients. Gordon Christensen evaluated our dentures for about a year and highly recommends them and put it in his clinical research brochure. He did study them for patients who have financial or access issues. This is a wonderful alternative for them. Having Gordon Christensen's recommendation is significant and I think important for a product. So the idea here was to have all the teeth taken out, have the implants placed, and have a Larell denture made for her to wear during the healing period of the lower. She had the upper done as well, but she was going to keep the upper because nothing was being done with that. Same process. The implants are uncovered 4 months later or 3 months later. The housings are placed onto the abutments. The areas inside the relined denture are relieved and then picked up with the same reline material. There are pickup materials for housings. Some of them are brittle. Some of them are just not quite as workable as the reline material that we use and recommend. And so we recommend using the same reline material to pick up the housings. We then try it in the mouth. We replace the temporary bushing with the final one, this final attachment. And again, we check it with articulating paper and pressure indicating paste. It's significant to do that. So those high spots that you can see there with the pressure indicating paste are relieved and the patient is comfortable. And this is the final patient, final placement of the denture. And this is a B1 shade. This is a lighter shade. And you can see she's a very attractive woman. And you can see the difference in her and just in how her eyes light up and whole face lights up. She was very pleased with that. And she was able to save the money on the dentures in order to do the implants. And everybody wins with that. The last clinical case I'm going to demonstrate is for, and I'll do this briefly, is for all-on-4 reconstruction. This is for placement of implants and fixed reconstruction. We do not use our templates as the final reconstructive piece. It is the temporary reconstructive piece, but it is fixed in the mouth during the healing period for the implants. So in this case, we have the teeth, upper teeth that are coming out. The implants are placed. A Larell denture is placed over it as a temporary. And I'm not going through the process, but there is a short process to take that template on the lower left and turn it into a fixed provisional. Analogs are put on, holes are drilled into the template, and the analogs are then, the abutments are then luted to the template. It's filled in with reline material and then finished so that this provisional can be screwed in to be worn for the 4 months or 5 months until the implants have integrated and can be restored with the final fixed restoration. So how do you market this? We market this by internal marketing, office newsletters, patient brochures, message on hold, photos of your patients in the office, and word of mouth. Our dentures create great word of mouth recommendations because of the convenience factor. There are many doctors who even charge more than the typical Larell fee for the convenience of having it done in one visit. And patients, many patients are absolutely thrilled to do that. External marketing is another way to do it. Local newspapers, Facebook pages, office websites, speaking to local groups, putting notices up in senior centers and other daycare centers, and visiting skilled nursing facilities and visiting assisted living residences. Those are great sources of patients. And because it's portable, you can go right into those assisted living residencies where patients are semi-autonomous, but they can't really transfer a lot. So they leave. They don't have to leave the. They don't have to leave the home. They don't have to leave the assisted living residence, and the homes love it because they are the ones who have to provide transportation, and so they don't want to provide transportation and staff to take patients to the dentist multiple times. So they're actually very happy to have you come in to be able to do that. And then I will tell you, administrators of assisted living residencies and skilled nursing facilities are all very, very cooperative and helpful in getting this process instituted. These are a few testimonials that we've received. The kit that comes from us has 10 templates, one set of each of the 5 sizes. It has a professional package of the hard reline material and the soft reline material, which I'll talk about in a second. It comes with the boiling pot, the occlusal plane plate, the tinting concentrate, and a DVD of the procedure. Now, the soft reline material is used in only a couple of instances. It's used when you have significant recession and resorption of the ridges, and you have to make a multi-layer reline. You can do that with first a layer of hard reline and then a layer of soft reline. So that's first. The second is if you have an exostosis or some other undercut that for whatever reason you can't prepare surgically, you can do the hard reline for the most of the denture, relieve it, and put in the soft reline only in the area of the undercut for comfort level, taking it in and out. The soft reline material will last 12 to 18 months. The hard reline material will last 5 to 7 years. It'll last as long as the denture will last. The teeth we use are Meyerson-Kenson teeth. They're a good grade of tooth, and they are used by most dentures in most labs. You can see the photo on the bottom. The kit comes with 10 templates. As a bonus for attending the webinar, we will add 3 more templates into the kit of your choice, or if you'd like, we can choose which are the most commonly used sizes. But we're happy to add that in as a little bonus for attending our webinar. Here's the way the economics work out. It's about an hour of time once you have learned the procedure. The cost of templates and reline materials is $375. That's the retail level. If you're doing more and ordering more, the prices come down. The suggested fee to the patient is $1,400 complete for the set of dentures. So if you consider that it's about an hour and the income is the $1,400 minus the $375, you are about at $1,000 an hour. Now, the numbers from the American Dental Association say that the average dentist makes about $175 an hour. This is net. This $1,000 an hour is net. If you are doing public aid, it might be $600 an hour. But $600 an hour is still 3 times what the average dentist makes. And if you have, as I said earlier, 15 to 20% of your time open, that's 1 day a week. And if you can fit it in with several pairs of these dentures, which you can if you promote, and you will get them, you can add over $200,000 to your yearly income with that open chair time. And that's how this works. If you did one set a week all year and took you an hour and a half to do it, you can see what the increase in income would be. It says increase in gross income, but it's really net income because there's no laboratory cost. The only cost there would be the fixed overhead cost. But if you do 4 sets a week, if you have one day, you work for 4 to 6 hours, fill in that empty day and do dentures, that's how much you can add to your yearly income. The interesting thing about doing it that way is if you set aside a half a day or ultimately a day, and there are many doctors who do this, just to do dentures, you'll even increase your net profits more because you don't need the full amount of staff, and you can get your office set up in a very efficient way to do the dentures and not have to be distracted by doing other procedures and fitting in the dentures. So that's how it really becomes profitable. So what we have is this innovative method for one visit method for denture fabrication. It's affordable for the patient. It's profitable for you. It's an easily learned technique. There's a huge market out there, 2 to 3 million more people every year becoming a dentulous. There is competition for dentures. You can see it all the time. I just read a research study from the Journal of Prosthodontics about CAD/CAM dentures. They're not everything they're cracked up to be. They are a minimum of 2 steps, 2 visits, and they're much more expensive. So this technique, the Larell technique, very low tech, is a way that we can provide the care for people who need it at an affordable level for them, and yet you as dental practitioner who's providing it can provide a great service and make a decent revenue increase with that. So that concludes this step of the process of the webinar. We're going to stop for just a second here, and we're going to switch over to the video. So now we're going to show you a video of the entire process, keeping in mind the aspects that we started with. The first step, of course, is template selection. We have the 5 sizes of templates. We take the alginate impression, pour up a quick set model, and choose the template that fits the model the best. They don't have to be ideal at first. This patient has their nose and chin marked, and these are her old dentures. And you're going to see when we measure these that she had quite a bit of collapse. And you can see the angular chylitis that she has with the collapsed bite. And there's her measurement. This is the measurement that she had when she came in. Keep in mind you can mix and match the template, so you can use a different size upper and a different size lower depending on what fits the model the best. So we have the impressions, and you can see as the model is tipped that there is quite a bit of resorption in the maxilla in the anterior, but look at how the teeth fit right over the ridge. And this is, I'm not sure what size it is, but probably one of the smaller ones looking at it. It looks like it's going to fit over. It does. It's close. It's not exact. It hasn't been touched. It's not ideal, but it's pretty close. Same thing with the lower. And now with the lower, because of the retromolar pad areas, it's harder to try the teeth over the ridge, but it looks, by extrapolating, that it does fit pretty well. You can see that the teeth are over the ridge. The template will have to be manipulated and trimmed in order to get it to fit like a good custom implant tray, impression tray. So the first step is to try it in the mouth. We're looking for how it's going to fit. We're looking for the midline. First thing to do, check that midline. It's critical. You can have the most perfect fitting denture, but if the midline's off, the patient is going to hate it, and that's your form for function. Well, we've tried the template in. We know that that's the right size of template. We've tried it on the model. We're now going to put it into boiling water and fit it to the model. We mark the midline. We're marking the areas where we're going to trim it. And as I said, at room temperature, this acts just the way standard denture acrylic would. We can mark the tuberosities, the flanges, everything we need in order to get this to fit. That's before we put it in the boiling water. We know exactly what's going to happen with that. So the templates are tried on the models. We know that we'll get a better idea and might have to go back and trim some more after the templates have been fit. We mark the midline because we want to cut out for the frenum. The midline is extremely important. When we try it in the mouth, and especially when we reline it, we want that midline in place. Now, you don't have to be exact with the relief for the frenum or for the tuberosities either, because we are going to have the reline material that's going to come out, and it's going to cover this area, and it's going to create the border molded flange that we're really looking for. We want to roughen it up, and so we just trim that. And as you can see, by trimming this with an electric lab handpiece, at room temperature, it acts just the way standard denture acrylic is. It actually is a standard denture acrylic polymethyl methacrylate, but it does have some additional ingredients to create the thermoplastic abilities. So the denture templates are trimmed. We want to take off where that buccinator muscle will come to try and get that as close we can to fit. Now you can see that the fit is much better. So we drop the upper template into the boiling water for about 45 seconds. Watch when he takes the denture out of the boiling water, how malleable it has become. And it's that malleability that we'll take when we put it on the model. So we're going to put it on the model. First, check the midline. Secondly, check the palette. That midline needs to be right on. Then the palette is impressed. Once you have set the palette and the midline, then you can replace it to the model innumerable times. You can see we're still able to mold that, but we'll go back and put it in the boiling water a little more, and then we will take the template to the boiling water again. And so we get a close fit. And as I said, it has no memory, so you can do it multiple times. So we have that in the boiling water. See how malleable that becomes? 45 seconds or so. We don't want it more than a minute or so. It's just depending on the elevation you're at. Higher elevations require more time. Place it on the model and form it. And you can see how he's forming it right to the ridge. That's how we get a close fit, so we have no more than 2 millimeters of space in between. So now we have fit the models to the templates. Templates fit pretty decent occlusion. Now we're going to take it to the mouth and reline the upper template. The first step, as I said, is to use a primer adhesive, and we are going to paint the inside of the upper template. Now we've tried them in. We know that we're going to be good on the vertical because we've checked that already. We know that the position of the template is good. Once you've done 1 or 2 or 3 sets of dentures, you won't need to put in tripodal stops. You'll be able to see exactly what you want. So we recommend, not what this doctor is doing, but we recommend using the ratios and proportions that the material comes with. It's Flexacryl by Lang Dental. It's a chairside reline material that's been around for probably 60 years. We tested about 20 different materials and found this actually to be the best material from a working standpoint, from a mixing standpoint, from a exothermic standpoint, from everything, including working time, and also it was the least expensive. So we mix up the reline material. At this point, basically you are doing a chairside reline. Is this the only material you can use? No, there are other materials that can be used. But we, as I said, we tried many materials and found this to be lowest bubble formation, most rigid setup afterward, just the best material. Once it's not runny, you can add it to the template and then take it to the mouth. See how that's barely running, which is good. That's what we want. We have about 3.5 minutes of working time. The color we choose is a fibered pink, which matches our templates, so you can get to the point where you see no line between the template and the reline material. You do have enough time to work with this. You'll get to see that when you're working on these, you'll know exactly how much. So we're now going to place it in the mouth. And you can see those sores in the corners of her mouth from the overclosure. Midline. The midline is placed first. Extremely critical. Then you'll see he places the posterior, puts posterior pressure to get that up posteriorly to get the occlusal plane. Now he had checked the template with the Fox plate, the occlusal plane plate, before starting, but he didn't need to do it at this point because of his experience level. But you can see visually the midline is on. You can see the elytragal line is on. You can see the Frankfurt horizontal is on. And now he's just going to do his border molding. And that's done in a standard fashion that you would do with any denture. Whatever technique you like for border molding, that's what's done. Sucking on the little finger with or without holding the nose does help seat that template. So now it's a matter of waiting about 3 minutes, about 2 more minutes, wait for that to be fully set. He's taking some Vaseline on a Q-tip right now to push the excess material off the teeth so that it makes it easier to finish. But all the while, as soon as the exothermic reaction starts, and most people don't even mind it at all and don't have to do anything about it, they tell us if it's too warm. That's what it looks like. You see there's a little spot there he's going to fill in, but you can see what the border molding looks like. He's going to retry it in to make sure that this fits. He has, the trimming has not been touched at all. Now if you see, he tries in the occlusal plane plate, and you can see that the occlusion, the plane of occlusion is correct with the elytragal line and with the Frankfurt horizontal. It's important to have those upper posteriors up, because if they're not up, you can have them hit the retromolar pad of the lower denture and the fit is not right. So he's now taking and placing the post dam. You can see it's just a hand mix of about 1 millimeter right across there. We're going to wait till that is completely set before it goes back in the mouth. And since it does take a couple of minutes, you want to make sure it's out of the hamular notches because that can prevent it from seating. Remove any spots that you need to remove. You can smooth it, and basically you have most of the finishing done on the post dam before you even put it back in the mouth. So there's what the post dam looks like after it's finished. Only about 1 millimeter high and only about 1 millimeter thick. The rough finishing and polishing has been done to the outside of the template. And now you're going to see the template with post dam being placed in the mouth. The rough finishing was done with in this case, a lathe, but you can use a Dremel or a lab handpiece. And you can see that this denture is tight. Now I've set the volume up right now.
Okay. Now just lift your lips for me and swallow. Very good. Say 66. 66.
I'm hoping you'll be able to hear this.
Church. Museum. Museum. Are they comfortable? Yes, they are.
The reason for that is I would hope that you'd be able to hear that, to hear the patient.
They feel like they belong in my mouth, and they're so comfortable. And they, I'm tickled to death with them.
And how was the process?
The process was great. It didn't take very long, and I feel like I can go out and have dinner right now.
That's great. That's great. Is there any final comment you'd like to make for us?
This process is amazing that you did, and I just love it. And the people who did it was just wonderful to me.
Thank you.
And I want to thank you very much.
You're welcome.